Good morning, everyone. Thank you for being with us. Thank you for all the speakers for the preparation and being connected. We have Institut Curie with Dr. Paul Cotu and Alexis Burneau.
So, hello, everybody. Nice to be here and nice to see you, Joseph. It's been a long time. And thanks to Pierre and Alexis for the invitation to giving this part of the talk. So we will have a talk from Institut Curie separated in two parts. I'm a medical oncologist, mostly involved in breast cancer care. I'm also the deputy head of the medical oncology department at Institut Curie. And Alexis, is more involved in palliative care. And so we'll have two different sections in our talk. So first, I would like to thank all the people who have helped us to prepare this presentation for you today. Of course, all the members, doctors, and nurses, paramedics from every Institut department who have worked so hard during the past 3-4 months for this COVID-19 crisis. And we are also indebted to Dr. Florence Bachelot from the Medical Information Department, who has done a terrific job in gathering all the figures for the activity that we had during these special weeks. Xavier Paoletti, who works with the Biometry and Statistical Studies Department at Institut Curie, and of course Pierre Fimolo, who is the General Director of the Institut Curie Hospital, who has managed in a particularly brilliant way all this crisis. So briefly, that's what we are. Institut Curie is a 3-hospital institution with 3 locations, one in Paris, where we're talking from today, which is in the center of Paris, which is shown in yellow. This is the yellow dot in this map of the region of Paris. We have a second location in Saint-Cloud, which is shown here in blue, and a third location in Orsay, which is in the southwest of Paris. I will focus on the Paris side because this is where I work, but you have to understand also that the decisions and the way we're organized were duplicated between the 3 sites. And basically, we had to deal with 3 main issues when coping with the COVID-19 crisis, which is patient care, and of course, we'll more focus on patient care. Second, how do we deal with visitors, the accompanying person and all the people who work daily at Institut Curie without being member of staff, and of course, the staff member, and I will go through this. First, if we focus on Paris, you see here on the upper left part of the slide a general map of Paris, and you see that our Paris facility is located in the very heart of the city, and which is magnified in the center of the slide. And you see that we have devised 2 separate entrances, one for staff, and they were checked for having masks and hydroalcoholic gel or solution in order to rinse hands, and then they were able to go to work. And there was another entrance which was dedicated to patients, and we had security personnel, which was posted every day from 7 in the morning to 7 p.m. who had to check 2 things. First, if the patients who were going to the institution had indeed an appointment with either a physician for chemotherapy or radiation therapy, for scheduled surgery or whatever. And they also had to stop and halt accompanying person in order to limit the number of people who were gathered in the institution at the same time. And then, once the patients had went through this first checkpoint, they were met by medical personnel where the temperature was checked, and they also had to fulfill a very short questionnaire in order to orient them either to the regular care if everything was okay, or to a dedicated COVID emergency room where physicians and nurses were posted in order to evaluate those patients, do PCR testing, CT scan according to the clinical presentation. And then either the patient were admitted, let's say they have a COVID-19 disease, or they went through the regular care path if everything was finally okay, or they were discharged home with or without therapy according to their clinical condition. So moving to staff, so we, of course, delineated specific COVID wards with several entrances for these wards into the institution. Of course, a mask and hydroalcoholic gel or solution were at the disposal of every member of staff. We had, of course, dedicated working outfits, and there were many education sessions almost daily at the beginning, just to make sure that all the nurses, you have a doctor here and a nurse showing how to put on these blouse and mask and cover for the head, and the glasses and specific shoes as well, and so on. More generally speaking about the way that the staff did work, so we implemented, as in many institutions, a large amount of working from home for secretaries, even for doctors. We had a weekly psychological supervisions for all the personnel, just to make sure that everybody was still able to cope with the crisis. And most importantly, we had daily crisis meeting with our director, Pierre Femolo, and the managing people at Institut Curie, in order, one, to make sure that we had the updated figures from France, from Paris and Paris area, and all the recommendations that were published by the government every day or every week. And this information was shared between the management of the institution, between the managing doctors and nurses, and then disseminated to all people in Institut Curie. And what is tremendous is that this has generated a great solidarity between caregivers, and of course the collaboration and the overall spirit of care has really improved during this crisis, and probably this is one of the most satisfying outcomes of this terrific situation. If we now move to visitors, we of course implemented very strict rules, and visits were severely restricted during the entire COVID-19 crisis, and they were limited to two situations. For inpatients, meaning patients who were already hospitalized, so only children had visitors, of course their parents, and end-of-life patients were also allowed to have visitors, their close relatives, one or two people at a time, and for limited hours during the day. For outpatients, meaning patients who had only appointments or a radiotherapy session or a chemotherapy course, the only situation where accompanying people were allowed were the first visits, so meaning the patients who were going for the first time to our institution for beginning the cancer care. All other visitors, for example, pharmaceutical companies, non-institutional colleagues, volunteers, etc., were strictly forbidden during the whole crisis, and they were allowed only a couple of days ago. Okay, so now let's move to the core of the question, which is how we dealt with cancer care for the patients. I didn't want to impose you a vast series of slides showing in detail how we perform, because I guess that in every institution and in every cancer institution across the world, we more or less did the same thing. There were general principles. So we have written and published some guidelines specific to, let's say, breast cancer care, GI, TBU, and so on. Most importantly, we implemented a daily multidisciplinary board for patients with COVID-19. We were very focused on patient consent with regard to cancer care. Can we postpone or should we postpone, and what will we do with chemo, with surgery? And this was very important. And as soon as possible, because as you may know, of course, the availability of the test was not that easy at the beginning of the crisis. But when possible, we generalized the RT-PCR testing. More specifically, for inpatients, we splitted all the rooms into single rooms. So, of course, we lost some beds, which is an issue. We performed regular PCR and CT scan screening for patients who were hospitalized for a long period of time. Again, we had dedicated wards, and we also had a dedicated Please, thank you for putting off your microphones. Thank you. And so we also had a dedicated intensive care unit with COVID-19 only patients. And we also implemented 2 dedicated operating rooms for patients who had to undergo surgery and who had COVID-19. For outpatients, so again, accompanying persons were forbidden except for the specific situations I've commented. Whenever possible, treatment were postponed. whenever possible, care was delivered at home. And as much as possible, we developed teleconsultation and video consultation for all these patients. There are also some specifics I wanted to underline today, which is we stopped or we didn't initiate everolimus, for example, some IO drugs with regard to the risk of lung complication. We implemented generalized use of GCSF, and of course, patients who did have to have a high-dose chemo were postponed, except for very special indications of the control of risk situation. So very briefly, what was the impact of this crisis on our activity? So you see for the three main clinical departments, the medical oncology, the surgery, and the radiation therapy, the differences between the 4 first months of 2019 and 4 first months of 2020, more or less, there was a drop in activity of 3 to 5%, which translated into a drop of income of 5 to 7%, which probably will be a problem by the end of the year, but that's the way it is. If we focus on the daycare clinic, because we have a daycare clinic where about 100 to 120 patients are treated every day. So you have in light the data for 2019, in dark the data for 2020, and you have the blue bars are for the patients who have long chemotherapy, let's say for 4 to 5 hours, so who consume a vast amount of time in the daycare clinic. And in yellow are the patients who have short IV chemo. And what you see in April and May is that we overall have a drop of about 20% of activity, specifically in the daycare clinic. And half of this drop was due to short IV chemo, but let's say paclitaxel, vinorelbine, and so on. But what's interesting that most of these treatments were performed at home. So this is a lot of activity for institution, but the patient was treated without being exposed to other potential COVID-19 patients or even physicians and nurses. This is the activity of COVID-19 patients, so week per week. So this is for Paris, and also in dark orange, and in light orange you have the figures from our Saint-Cloud facility. So you have the weekly cumulative number of patients who are admitted with COVID-19. There was a peak in week 17, that's more or less the beginning of April, when the peak was present in France. And the green curve is the cumulative number across the weeks, and the red curve is the cumulative number of deaths across each week. So we have reported those results, and they should be published very shortly. You have received 2 abstracts from the paper, who is going to be released momentarily. So showing basically that the patients who had a poor outcome, meaning the patients who were either admitted to ICU or deceased from COVID-19, the main prognostic parameters for poor outcome were the clinical presentation, dyspnea, and the decrease in partial saturation in blood oxygen, or the extent of lung disease as per CT scan. Of note, patients who did not have breast cancer were at a higher risk, even if not statistically significant, to develop complication, and patients over 70, which is commonly observed for COVID-19, were also at high risk to develop a poor outcome. And now we move to palliative care.
Thank you very much, Paul. Thank you very much. So, palliative care have had an important place during this health crisis, and they were located at the heart of a new organization with a full collaboration with oncologists and palliative care in the COVID zone. At Institut Curie, the palliative care team's activity is divided into 2 main areas. First, for ambulatory patients with consultations, few teleconsultations, and daycare hospital for multidisciplinary assessments for more than 1,000 patients a year, links with emergency departments, and links with home care service. For inpatients, mobile team activity in the department, mainly in oncology department for palliative expertise, assistance in relieving refractory symptoms, support for patients and their relatives, assistance for end of life, and assistance with discharge project. Finally, the organization every day of a multidisciplinary staff consultation to assist in the decision-making process for advanced cancer patients, in particular, the cessation of chemotherapy. Because of the new situation related to the pandemic and the containment, the usual requirements of palliative care are not feasible. Prohibition of visit, distance from patient, hidden face, modified death procedure, no exposure of the disease. And prohibition of visit, distance from patients was the most difficult measure for all, with a significant psychological consequence for relatives and carers. Our palliative care activities has been concentrated on two areas. One for cancer patients already in palliative care but COVID-free, and second for cancer patients but in palliative care because with a new critical COVID disease. For this first group, non-COVID palliative patients and their family refuse to go to the hospital, refuse hospitalization. It's why we developed more than 90% of our consultation into teleconsultation. And we transform day hospital because we rescheduled many day hospitalization after a video medical assessment. Our psychiatrists, psychologists, volunteers provided teleconsultation. And we had a collaboration more with home care service, so there were more end of life at home, and we developed links with them. Another activity was for patients hospitalized with COVID disease, but abruptly into a palliative situation by a severe form of the viral disease. This was a palliative emergency marked by the announcement of the COVID diagnosis. And announcing a positive COVID diagnosis to a patient in advanced cancer is equivalent to the announcement of a serious and possibly fatal disease in a short term. So this requires tact and accompaniment for the patient and their relatives. This is a source of great anxiety. These palliative care teams was present every day in the COVID zone to help to relieve refractory symptoms, in particular the breast distress, disseminate new recommendations and accompany relatives at distance. We have developed a new procedure for care of the deceased according to the regulation, and finally, we established a multidisciplinary board open admission to assess the level of care in case of deterioration. And everyday participation to telemeeting for complex case, ethical problems. So in summary, the crisis was an opportunity to develop teleconsultation and video means to work together and consult each other. We have suffered, of course, from containment, restriction of visit, poor science information, remoteness, and our fatigue over the weeks. We retain in perspective the video tool as a clinical aid and communication aid for our oncopalliative board. We retain the management opportunity with teams more capable of making a proposal and our organization that is much more attentive to the care teams for the decision making. We want to keep this collective spirit, you have spoken of that, of collaboration and name together the keys that have allowed us to succeed, maintain the multidisciplinary meeting via tele-expertise for decision to stop treatment of inpatient and maintain the level of relationship with management. I would like to thank you, many thanks to 2,500 NCT staff members. 75 were diagnosed COVID positive by PCR and 1 died. NCT and NCT Pasteur together developed a new clinical trial to assess the immunity of all NCT staff with a serologic test. And after 4 weeks, 1,650 staff members were tested and 20% was diagnosed with a significant level of antibodies against SARS-CoV-2. So continued follow-up is planned for all for 1 year with a regular testing. Thank you for your attention.
Well, good morning again. This is I'm Hikmat Abdelrazak. Next to me sitting is Dr. Omar Shamiya, the head of the Palliative Care Department at KHCC King Hussein Cancer Center. Okay, this is the epidemiology of COVID-19 in Jordan. As you see here, things started back in March, 3rd of March, when we had the first case of confirmed COVID-19. It wasn't until 2 weeks later when we start seeing the other cases. As you see, those diagram represent the data until mid-May, and as we speak, data is very similar. The total number of confirmed COVID-19 in the country is a little more than 1,000, less than 1,100 so far. And most of those cases had recovered. We only had 9 deaths so far. However, we do admit, or the government actually do admit each and every COVID-19 patient, regardless of the severity of their infection. And they do a good job in checking whoever had any kind of contact with those confirmed cases. And because of the major lockdown in the country and the shutdown of airspaces and even the local borders, we managed to contain all cases. And this is probably a unique data and unique epidemiological things that need to be addressed in the whole world. I mean, to my knowledge, none of the countries that we know had to admit each and every case and contact each and every contacted person and test those. We at KHCC were part of this. We are the cancer-specific hospital, so we decided in collaboration with the government that the regular cases of COVID-19 will not be admitted to the center, even if the patient is diagnosed with cancer, unless the patient is in active treatment where cancer care need to be delivered. So what we did in our center, similar to our previous colleague discussion and the data presented, we had a drive-through screening. If we can go to the next slide and go back to the slide, Pierre. This is the early March. We established a drive-through screening, meaning we emptied our parking lot and the cars and visitors were directed to enter the garage. As you see here in the photo, 2 nurses would check the driver and the companion, would take the good history and they check whether they have any recent travel or contact with the infected or affected person. They take the temperature, and once the patient or the companion screened, they were tagged with the date, and they were allowed to enter the building. So nobody can enter the building unless they go through this process of screening. Then through this drive-through screening, we also limited access to the medical ward. So visitation was cancelled. We only allowed 1 visitor per patient, and that visitor need to be specified. So all through the hospitalization, patient can be visited by 1 pre-specified person. Exceptions were made to the patient in ICU and in palliative care for a dying patient, where we did allow limited visitations. We also in the clinic had limited companions. Only 1 companion would have an access to the outpatient building. As you know, in this part of the world, we used to see like 4 or 5 and sometimes a lot more companions with each patient coming to the clinic. So we did a major limitation in this regard. We also limited the access to the waiting area, limited the number of chairs to assure social distancing. And we also did the telemedicine. So we allowed only 25% of the patient to load in the clinic to be seen physically. And the 3/4 of the patient, we did what we call a telemedicine, where a patient was called the day before the appointment that your clinically was rescheduled to be a telemedicine, that you have to be available at home at this particular time, and the physician and the clinic coordinator would call you, check in you, and take the history, and have a treatment plan. And with that also, we had to modify our clinical practice guidelines. We have some limitations on what kind of chemotherapy can be given and what not. We also modified the intensity of the leukemia treatment, for example, during the first weeks of the COVID-19, not knowing which way the country would be going. We were looking around and seeing lots of the countries in Europe and in the States having lots of cases. So just in case, we have to limit the intensity of the chemotherapy delivered even for the leukemic patients. We also managed to deliver all outpatient medication using an overnight carrier, and the hospital would pay for this to the patient, so patient didn't have to come to the hospital to pick up their medications. Omar will be talking about the home care. We enhanced our home care facility and capabilities, and Omar will address this during the second part of our talk. So this is we took the breast cancer as an example of the impact of COVID-19 in cancer patient, and I'll share with you what we did and what we observed in breast cancer. As you see here, screening mammography and early detection centers had almost ceased during those past few months. We have also mobile units were previously established to enhance screening effort in remote areas. Those were also completely shut down. We have also significantly lower number of new breast cancer diagnoses. As such, most of those patients will present with more advanced stage diseases down the road. These are the number of breast images. You see in the upper yellowish curve the total number of breast imaging studies, that is the ultrasound, mammography, MRI, and other diagnostic procedures. As you see, through the month of March and April, we had a significant reduction in the number of those procedures. We went down from close to 2,000 procedures a month to less than 500 during those months. And the major reduction was in mammography and ultrasonography, with also a negative impact on the number of diagnostic procedures that we have to do for breast cancer patients. This is the curve on the left in blue, the total number of new cases seen at King Hussein Cancer Center during those months. We used to see close to something between 500 to 600 in new breast cancer per month at the center, and that had dropped to around 100 and 150 cases a month during the month of March, and even further reduction in the month of April. And a similar curve in red on the right side, you see the number of new breast cancer cases. We see 100, 120 new breast cancer per month. During those months, we used to see a lot lower, 20 to 30 cases per month, which means, as I illustrated before, more than 90 or 80 cases left undiagnosed and untreated in the community just for the breast, and close to 400 other kind of cancers left untreated, undiagnosed, unattended in the community. Now, the curve on the left represents the chemotherapy, and the curve on the right represents surgery. As you see here, we used to deliver close to 1,400 sessions of the chemotherapy a month, usually. During the initial impact of the COVID-19, the first 2 weeks, we reduced the number of chemotherapy delivered. We also canceled all palliative chemotherapy, all metastatic disease during the first 2 or 3 weeks. Once we recognize that the country is not going to a bad situation, and the number of the cases in the country has not alarming. So we managed to kind of relax a little bit and allowed to deliver all kind of chemotherapy actually, except for the anti-leukemics. So as you see in the curve, we had no major impact on the number of chemotherapy delivered to our patient during those months. So whoever already established on chemotherapy managed to get to their chemotherapy on schedule. Only during the first 2 weeks, we had some reduction. As you also see in the number of surgeries, we limited the number of surgeries to the urgent one initially, but we picked up very soon. We now, in end of June, we're back to our usual schedule of daily surgeries without any negative impact. Now, the negative impact on delaying the diagnosis, I left it to the empty intentionally because God knows what is the negative impact. I mean, there's no data in what is the volume of the undiagnosed patient, unattended patient, either locally, regionally, or internationally. We recently submitted a paper looking at the negative impact of delayed diagnosis and treatment of breast cancer as an example. We already have the data on significant negative impact if we delay surgery, if we delay neoadjuvant chemotherapy, if we delay adjuvant chemotherapy, and if we delay radiation therapy for breast cancer. So data exists that a delay beyond a month or 2 months in treating a patient with breast cancer, especially those with aggressive behavior like triple negative, would have a negative impact on the outcome. So that's for breast, and similar thing can be said for lymphomas, for testicular cancers, for leukemias, those potentially curable kind of cancer. So we're in the process of collecting some data to see what is the negative impact. Now, once we open the full-blown nowadays, we start to see now lots of the advanced stage breast cancer patient, for example. We have seen lots of lymphomas, the unattended. We've seen also unattended testicular cancer and germ cell tumors. As you know, those are all potentially curable kind of cancers. So the whole community, international community, will start to see the negative impact of delayed diagnosis. Our government, our hospitals have done a remarkable job actually in limiting the impact of the COVID-19 spread in the country. But unfortunately, they failed to attend to other NCDs, non-communicable diseases. They failed to attend to patients with chronic illnesses. They failed to attend to patients with the cancers. All major hospitals, private and governmental, had limited the access to such patients. So nowadays we have major impact not only in cancer, but in all other NCDs, diabetes, coronary artery disease, and delaying any major surgeries. So in the near future, I think the whole international community will see the negative impact of just focusing on the COVID-19 and forgetting that there is lots of the other disease entities exist in the community. Then we'll move forward. Dr. Omar Shami will continue his palliative care part on this. We'll take questions at the end as already suggested.
Thank you, Dr. Hikmat. Thank you, Pierre, and the team, Alexi from Curie, for having us with you in this important webinar today. As previously alluded by Dr. Hikmat, before we go with the statistics, I'd like to say that palliative care service in KHCC is one of the largest palliative care service in the country and the region. We have 4 types on 4 models of care delivery, including palliative care inpatient service and also a palliative care inpatient consultation service, in addition to the ambulatory care clinics and also a unique home care service which covers home hospice as well as home services for actively treated cancer patients. Now, looking at the impact of COVID-19 on the palliative care service statistics, I started with this graph looking at the number of consultations and referrals compared between 2019 and 2020. On the left-hand side, as you see that we had a drop actually, compared to the last year, we did not see a drop of the services. However, we have seen actually some increase after the month of April, although between the month of March, early March and April compared to the last year, the numbers were less. But as we started opening up the services, we started having more consultations. And also on the right-hand side, we see also a surge of palliative care referrals on the month of May. That reflects the number of admissions increased after the opening up of services at KHCC. Also in the palliative care clinic, although we have seen a decreased number of patients coming physically to the palliative care clinic at KHCC, we continued to see patients, as Dr. Hikmat mentioned, via teleconference and sometimes video conference, depending on the patient situation. And of course, this needed a learning curve for the staff to be able to assist patients in a comprehensive way using phone without seeing the patients physically. On the other hand, the home care services, as Dr. Hikmat mentioned, we managed to increase the number of home care teams from 4 teams to 5 teams. And we had actually to place home care nurses in areas where the lockdown is there to have nurses who live in that area just do the visits in that area without needing to come to the hospital. And we managed to deliver supplies as well as the medications to those areas, like in northern province Irbid in Jordan. So we tried to compensate the decreased number of physical presence of patients in the clinic by actually allowing the home care team to go in person and evaluate those patients in need at home. And taking into consideration the reduced staff exposure, so we did not allow teams to meet in the hospital, and we had to segregate the areas where they come and the time where they come to refill supplies in the hospital. The other important factor that we struggled over the past years to allow patients to die at home, because there was easy access to the hospital and patients at KHCC did not need to pay for any additional expenses if they decide to stay in the hospital until end of life. So in 2019, looking at the first 5 months in 2019, we had 0 patients dying at home. However, luckily, through this COVID crisis, we managed to allow patients to die at home without compromising the care. So, as you see, there was an increasing number of patients, between 2 patients before the crisis in January and February, up to 16, up to 22 patients in May, which is very, very important. And I feel that this is a positive consequence of this COVID-19 crisis, because patients and families were actually agreeing to the fact that it's better for them to stay at home with the help of our home care team. And hopefully we will be able to continue this in the next few months, even if the crisis begins to get away. So looking at the recommendations of how to respond to this, looking at systems, hospitals, we try to do this at KHCC. There should be flexibility and rapid adaptation of policies, guidelines, procedures that the hospital follow. In addition, this is mentioned by Dr. Hikmat and the colleagues, that limiting visits, hours and persons, whether inpatient and outpatient, although there was some, we have to be very careful with patients who are dying to allow their loved ones to come and visit them. There should be a rapid triage in the ER, especially for those patients who are suspected to have COVID-19, and we managed to have separate units to triage those patients and very quick testing for them to be able to decide whether they go in the regular floor or the isolation floor. In addition, we had to limit the admissions for cases which we feel that we can manage at home, and allowing our home care service to manage those patients remotely. Virtual service is something which is all of us all over the world probably are not 100% trained to do, but I think this crisis has helped us to see that there are some things which we can manage virtually, especially for those patients who are living away from our hospital, like 300 to 400 miles away. Volunteers, although we stopped in general volunteers, but these volunteers can be very helpful in the community, not necessarily coming to the inpatient facility. Regarding ethics and DNR, we published a paper about DNR changing policy at our hospital. The core of this policy change was, just in case if we have patients who are at end of life, we are allowed to actually sign in behalf of the patients and family, just in case if they are terminal. In our institution in the country, the family and patient agreement is a must before allowing DNR order to be in place. However, just in case if we have huge number of terminally ill patients in our hospital where the resources will be limited, we thought that we needed to discuss this with the family and convince them to allow these patients to go peacefully without heroic measures. So unfortunately, we did not need to do this till now, but just in case, we are prepared if the resources are limited in our hospital. As far as the human resource management, communication and coordination are very important, and as you see, staff protection, flexibility of rotations and hours of operation to allow individuals who can work from home to do their work from home, and limiting the staff contact. Interdisciplinary involvement is very important, and this also can be done in a virtual media. Looking at the staff resilience and screen for burnout is very important, because not to allow this unseen or unscreened. So we managed to sometimes to cut down the staff presence in the hospital to less than 50%. So looking at the palliative situation, it's very, very important to have, although in the virtual environment, to have very adequate screening using standardized tool, not to miss anything. And also, sometimes we manage to get even interdisciplinary team to do the clinic assessment, sometimes even for the home care team. So we do interdisciplinary assessment for patients at home, in the presence sometimes of the home care team or without the presence of home care team. Now, the government here in Jordan allows only 10 days prescription for patients with cancer. During the crisis, we managed to get an acceptance from the JFDA to allow us to prescribe this for 20 to 30 days for patients who cannot come to pick up their medications. Psychosocial support is very important. We continue to do this also for the inpatient and the home care. And we have to, as you know, that pay attention to the stress which is impacted over the patients and families due to quarantine and isolation. Communication is very important, and I do not want to emphasize more. It's already emphasized by my previous colleagues. Active listening is very important, even in the virtual environment. So we have to actively listen to the patient's problems. We need to continue education and counseling, support our patients, and also continue to expand on our home care services as much as possible. I think with this slide, I have to conclude, and I would like to thank you again for Dr. Hikmat to allow me to do this with him, and also for our Curie colleagues, and also for all the listeners to this webinar. Thank you very much.
Thank you. Thank you. Thank you so much, Dr. Omar and Dr. Hikmat.
Yeah, I would like to thank you all for attending this session. In particular, Institut Marie Curie and Dr. Pierre Nhouri for inviting us to this webinar. Also, I would like to thank ESA for hosting us this morning. Professor Attan and I will describe our Lebanese experience during the COVID-19 pandemic. Lebanon is a Middle Eastern country with an estimated population of 6 million inhabitants. The first confirmed case was declared in 21st February. As per June 18, a total of 1,495 patients tested positive by PCR for COVID-19, among which around 950 cases recovered, with a total of 32 deaths, 2 of them being lung cancer patients. When comparing the Lebanese experience to other countries, you can find that the Lebanese government provided with strict and rapid measures directly after the first case. In fact, we witnessed school closing. It was immediate, followed by a partial lockdown of the country on March 6, then a full lockdown on March 15, within 2 or 3 weeks of the first declared case. At the institutional level, we witnessed a variety of measures to ensure the safety of the patient as well as that of healthcare provider. As you can see, the experience of 2 different institutions go with the same flow, at the same pace, at the same time. In fact, at my institution, Notre-Dame de Secours, Jbeil, by March 9, we prohibit physician travels and establish a checkpoint areas in the hospital at the hospital entrances. We mandate also the use of face mask to personnel and patient, and reduce outpatient visits and restrict the number of visitors to 1 visit with each patient. Also, specific measures were taken regarding cancer patients, as sanctuarization of hematology oncology department. Also, patients with respiratory symptoms were isolated in a specific unit outside hematology oncology department, and we proceed to fund screening for all patients coming the next day for chemotherapy for any suspicious or symptoms or any exposure. Also, some measures such as for patients with indolent metastatic cancer, we have discussed to give a break. The same rules apply at other institutions, Hôtel Dieu de France, and after that, Dr. Attan will elaborate on this. At the national level, the Lebanese Society of Medical Oncology developed the following recommendation. First, they recommend screening patient and visitor for suggestive symptoms. They recommend also to refrain from admitting confirmed COVID-19 cases to oncology department. LISMO suggested modifying treatment regimen in order to minimize hospital visits by favoring curative therapies over palliative treatment, and delaying or withholding anti-cancer treatment when justified. They recommend also sanctuarization of the oncology department by withholding anti-cancer treatment for positive COVID-19 cancer patients until full recovery, and avoiding overcrowded clinics by favoring teleconsultation. They suggest to stratify patients into 3 risk categories, if you want. The first group of patients are stable patients on follow-up, or those on oral, endocrine, or targeted therapy. For such a group of patients, they suggest to delay visits in the absence of any new symptoms, and to delay follow-up appointment, and when we need, we can contact patient by telephone or a telemedicine. The second group are patients with early stage cancer or curative setting. In the curative setting, they recommend to discuss risk versus benefit of adjuvant therapies with patient and to consider limiting duration of adjuvant therapies when appropriate. For example, patient with colon cancer, those with a good risk stage 3, they recommend to do 3 months of adjuvant therapy instead of 6 months. And they also recommend to choose a 3-weekly regimen instead of weekly regimen. For the third group, those patients with metastatic disease, they consider to delay treatment or giving therapeutic breaks in indolent cases. Also to consider oral alternatives, such as a patient on vinorelbine IV can be switched for vinorelbine per-os tablet, and to manage patient toxicity via telemedicine. All these recommendations were published in Future Oncology, and now I will leave the floor for my dear friend, Professor Attan, to continue this presentation. Thank you.
Thank you, Marcel. Good morning. My name is Joseph Cattan. I am the head of the Department of Hematology Oncology at Hôtel Dieu de France, the French University of Beirut. I will move to the next slide. Yes. So, hi, Pierre, Paul, and Hikmat. I'll start with an attractive title, On COVID SWAT. What is On COVID SWAT? In fact, to explain for you what's the meaning of this attractive title, On COVID SWAT, here we are in the 1st of April 2020. That means 2 weeks after the implementation at the national level of the LESMO recommendation, of our local recommendation at Hôtel Dieu. The afternoon, we don't have clinics. There was a quarantine, a confinement, and a sensation of some kind of depression. So we create in our department what we call a working group with the name of On COVID SWAT. This working group includes my 6 oncologists in my department. Also, there were 6 fellows. And the ultimate goal of this group is to increase the rate of our publication. Very simple. So we motivate all participants or members of the group to publish based on some objectives like brainstorming, if we have some research idea, grouping COVID-19 and cancer, to evaluate the medical approach or specific behavior of patients facing the COVID-19 pandemic, to have observational studies, and to write editorials or review articles. So our first, yes,
you have
our
it now.
first article, but I put it as publication number 2 since the LESMO recommendation was number 1. The publication number 2 was the study of the implication or the impact of the implementation of Hôtel Dieu recommendation on our patients, especially in our daily care clinic. In fact, we didn't have any reduction in the number of patients who come or who were referred or hospitalized at the daily care clinic during the months of March, April, and May. The number of hospitalized patients at our OPD during each month was almost the same as the months in 2019. So the admission were around 720 admission per month. Despite that, all these patients were following the recommendation or even the physicians are following the recommendation to postpone chemotherapy, to convert injection chemotherapy with oral chemotherapy, to implement some restrictions to patients, what we call prioritizations. But despite that, the patients were reluctant to accept any treatment modification or even to accept any therapeutic pause, despite the interventions of oncologists at the level of the patient and at the level of the family. Why that? Because we think and we check for this that our patients have a greater fear of their disease, their cancer, the progression of their cancer, compared to the risk of catching the virus. The publication number 3. Also, we published to review articles and editorials, what the oncologist needs to know about COVID-19 infection in cancer patients in future oncology. It was number 3. To the right, publication number 4. Do checkpoint inhibitors compromise the cancer patient immunity and increase the vulnerability of COVID-19 infection? It's a classical question concerning the checkpoint inhibitors. If they interfere with the patient immunity, in fact, the response was negative. Publication number 5, dealing with the telemedicine for cancer patients during COVID-19 pandemic between the threats and opportunities. Publication continue. Each day we have new publication. Publication number 6, the management of patients with metastatic prostate cancer during the COVID-19 pandemic, very specific era. Metastatic prostate cancer, it's better to deal with them and treat them with hormonal therapy, second manipulation, re-challenge with hormonal therapy during the pandemic instead of moving to chemotherapy. Publication number 7, we have to remember always that during the COVID-19, if we have any pneumonia with radiological symptoms mimicking the COVID-19, to remember that these patients treated with immunotherapy, for instance, could have a classical infections like pneumocystis carini and opportunistic infections. It was at the left, the publication number 7, a case report published also concerning a melanoma patients treated with Nivo-IPI, hospitalized in the ICU for pneumonia and hypoxia. We thought that it was a case of COVID-19 because the scan, the chest scan, showed some characteristics of the COVID-19 pneumonia, and in fact, it was a pneumocystis carini disease. To the right, cancer patient and research during COVID-19. It was the publication number 8. Publication number 9, targeted therapy for cancer during the COVID-19 pandemic, a threat or a blessing. Publication number 10, hematopoietic stem cell transplantation dilemma during the COVID-19 era. And the questions here was, for how long can we postpone transplantation and intensifications for patients who really need that during the COVID era? And with the last slide, can we move to the last slide? The list of publication continue. Here we have cancer patient in the era of coronavirus, what to fear most. It's in press, in Journal of Patient Safety. The Chronicle of CML during the COVID-19 pandemic, also it's ongoing. Lebanese doctor, it's a questionnaire addressed to all Lebanese doctors, not only oncologists, facing the SARS-CoV-2 pandemic, practical and ethical issues accepted in BMC medical ethics. Bladder cancer during the COVID-19 pandemic, the calm before the storm, because it's a true problem, for instance, in bladder cancer, where patients, they skip the regular cystoscopy for instance, the papillary tumor. We will end up at the end in 2 or 3 months with advanced disease and infiltrating tumors. So it's not the whole list. We still have ongoing publication, and it's a proof that we can have some innovative idea, some benefit and direct benefit during the catastrophe and we end up with more publication and with more enriching CV for our fellows. Thank you for your attention.
Good afternoon, Professor. My name is Tu Dao from Vietnam. I present for my hospital, it's Vietnam National Cancer Hospital, about the cancer patient in age of COVID-19. Yes, the content we would like to present today about, firstly, we have COVID-19 pandemic and situation in Vietnam. And secondly, we would like to present the prevention and screening for COVID-19 and how we manage suspected case, and we do social distancing and application in clinic in a cancer hospital. And we will go into the conclusion. This is situation in Vietnam, and we touch very early. Okay, my country is very close to the China and Wuhan city, and we start the own procedure very early. For the 3rd January we were started temperature screening for all the Wuhan traveler, and 1 week later we established the national and local steering committee for COVID-19, and in the end of January, we confirmed the first case in Vietnam. This is reported from the Wuhan, and in this case, we are activate the emergency epidemic prevention center in Vietnam, and in the end of January, we confirmed the first local transmission cases. Sorry, the internet is not well. Okay, and the early February, my country closed some of school, closed all of school in a national level, and we quarantine and screening all the passenger from affected country, and in the 12th February, we locked down affected some region have many cases, and this is one village from we have some passenger come back from Wuhan. So in this situation, in the end, in the March, and we have many new cases, and this is the pandemic is coming in the war, and we have we do many procedures like health declaration form for all passenger, national school closed indefinitely, and universal health declaration, and in this case we close many all the country and do the social distancing. So the COVID after this, the March, many harsh procedures were done, social distancing and lockdown the region and country, and the pandemic problem came, and the cases is decreased, and the recurrent recover case is increasing. So in how experience in our hospital for the COVID-19 issue, we just minimize the case that come to hospital, and we didn't accept the patient come the low level of the country. Example, in the Vietnam, we have a country the contract of all patients in the north of Vietnam come to K hospital in my hospital. So in the situation of pandemic, the patient stay in the province hospital, and for 1 month in between March and April, and for 1 month social distancing at whole country. Patients stay at local and decrease the cases and decrease the patient come to hospital and the consultation. And after 1 month, the number of patient, the number of COVID-19 and cases decrease. So how we manage the suspected case, and we define the suspected case according to Vietnamese Ministry of Health, and this including the patient have a symptom and have a history, arrival, stay, and return from the COVID-19 disease outbreak area within 14 days, and or patient have any symptom of COVID-19 and contact with the COVID-19 cases. For everyone who have at our hospital, we must to check epidemiology, body temperature, and respiratory symptom. When we detect a suspected case, we refer this case to the isolation unit. The suspected case we in my hospital, we established in the end of March unit for isolation, and in this unit we take care of the suspected case with cancer. So this is the information. The photo of the cases is our hospital is very complicated for the money and everything, and we must to train some container go to the room. So for the cancer patient, we must to define the high risk population of COVID, including the patient receiving the chemotherapy, who receives chemotherapy at 3 months later, 3 months, and receiving extensive radiotherapy, and who have a bone marrow or stem cell transplantation, and with some patients with hematologic cancer, and that damage the immune system. And we also define this population with impaired immune system due to leukocytopenia and low hemoglobin level and long-lasting immunosuppression. So for all the patients, we must to find the high-risk patient to take care of this, and we also balance the control, the cancer control and risk reduce of COVID-19. For healthcare, we must do healthcare education for all the cancer patients, and they must to understand, avoid crowded place, and wear PPE when the patient attend the hospital or for visit or treatment, and correctly wash the hand according to the WHO indication, and do not have a contact with friends related with COVID-19 symptom or living in the endemic zone. And we also guarantee social distancing with all people. For two group patients, we must to off treatment for some patient and on treatment for the patient with the neoadjuvant curative treatment, and or some metastatic disease, but in ongoing in the progression period. For our patient, with this for the cancer patient, we should be reduced to safety and most feasibility level without geopolizing patient care. We delay on the follow-up visits. The patient must return to oral treatment, and we supply the more drug for course, and if at least we supply for oral drug for 2 months. And we also do the remote monitoring by blood test and local lab and telephone contact. We minimize number of inpatient in the hospital day, and we also minimize the number of day care in the hospital and the treatment. We limited the family come to hospital with patient. Only one patient must to have one family, one people meeting, go with them. We also implemented the services. We do the consultants online in all of the periods, and we continue this consultation until now for the COVID-19 and cancer patient. We do the online meeting and social distancing. In this example, all the patient come to hospital to screening, to screen COVID-19. And we do the website declaration, telephone declaration, and we develop an app for my hospital for the patient and caregiver and healthcare worker. This example of isolation unit. This the consultants involved and the social distancing between the patient over 2 meters. The consultation with patient COVID-19, and in conclusion, our country just initial successes in the prevention and control of the COVID-19 epidemic. We should have a further proactive and a comprehensive in community health preparation for the different scenario for COVID-19 epidemic in the coming time. So thank you so much, and we are here for join in the meeting and benefit the experience from your country, and we learn much more for some maybe different specific scenario in Vietnam. Thank you so much.
Thank you very much. And again, we know your hospital, and we know how hard you work and in this program. So now I would like to invite Abdel Maula, the head of research center in ESA Business School, who was listening carefully to the presentations. I think you worked on the questions, and so please, it's up to you now.
Thank you very much, Pierre. Thank you very much, gentlemen. I'm very impressed to be in contact with such a panel of specialists, and I'm learning a lot. Thank you very much. I would like to present a little bit myself. I'm the head of the research center at ESA Business School. Why ESA is there? Because we work a lot on health management. We have a master on health management. We do have several research programs on health management. I work, and my team is working a lot on hybrid organization and health systems. So this is one of the reasons why we're here. Personally, I'm a specialist of strategic and change management, and discussing with Pierre, we discovered, and it's obvious, that things are changing in your hospitals. So we are just trying to understand how and why. And listening to you, there are very interesting things just emerging. I was listening to Mr. Coutu, I think, who was saying that we discovered that we are able to work with management. And this is quite interesting. Why and how?
Thank you for this very good and tricky question. And indeed, yes, we have discovered that in some extraordinary circumstances, we were able to work closely with our management, which is not that obvious in the normal times, where usually the financial issues and the power, the use of power is sometimes a very hot topic of debate. And in this exceptional period, we have been able to overcome that. And this is, of course, a lesson for the future.
Thank you very much. I was also listening to your Jordanian colleagues saying, if I understood correctly, and excuse me if I'm wrong, but you were saying that, in fact, you used a lot of home care in Jordan, sending your teams to the eventually having an end-of-life follow-up into the families. And I was thinking, it's possible to do it in Jordan. It's eventually possible to do it in Lebanon because our social structure and family structure are able, we are able to have people at home taking care of the adults. And I was just wondering if it's possible, for example, in France, where the family structure is different, where the usage are different. So do you think that you can just replicate the Jordanian experience, and I understood some of the Lebanese experience in that respect, and that's in the West, Canada?
Abdelmaula, we cannot hear you very well. Can you summarize your question? I think the question is for Jordan. Can you summarize your question clearly?
Yes.
Thank you.
The question was, is it possible to adapt the home care system used, if I understood correctly, in Jordan, in countries like France or Canada, due to the difference of social system?
So the question then has to be probably answered by our colleagues in Curie. However, in Jordan, the home care system or home care teams are employed under the umbrella. Hello?
Yes.
Yeah. Under the umbrella of King Hussein Cancer Center. So the staff who are employed by our hospital, they are specialized to do home care services and visits. Now, although this is actually new to Jordan in the past probably decade or two, because of the complex social system, in order to overcome that and minimize problems, we opted to have two members of the home care teams, a female and a male nurse, to visit patients at home. However, during the crisis, we managed to allow the nurse to go by himself to visit patients. And in case if they needed, for example, specifically a male nurse or a female nurse, depending on the clinical need, we will adapt this and respond to this accordingly. I think home care team, and Alexi can correct me, in France, in Curie, they do have patients under home care. However, the home care team is a separate company, and Alexi can take this from here.
What we experienced, and Alexi was sharing this with us just now, home care is owned by a company we use on a day-to-day basis, and they merged with us in terms of behavior. And there is a lot to learn. This is the target of this webinar. We wanted to learn from Jordan. We wanted to learn from Lebanon and Vietnam, and this afternoon from other countries, because we can adapt our program and home care program, because they are going to be, it's going to be before and after COVID. And actually, patients were managed at home in an incredible manner. And the tools we developed, the approaches we developed are going to continue. And everything we learned from you in Jordan will be really integrated and it can influence us also.
In Institut Curie, my staff doesn't work at all. So we have a collaboration with home care service, and they have their office in our hospital. And we had a good collaboration with them during the crisis, because their staff continue to work, and we increase the level of this collaboration. We increase the possibility of chemotherapy at home, end of life at home, lot of care at home, and reduce the coming in hospital. And we will continue this level of collaboration after this experience.
Thank you very much. I do have eventually a lot of other questions to ask, but the time is really short. So what we are going to do as a team, a research team, we're going to screen your presentation, listen again to the presentation, just begin to analyze if I may, I would like very much to be able to have one-to-one meetings, e-meetings with you, to go and see further and have more details concerning your experience, how you do things. And as Pierre was saying, the purpose, I guess, is to share our experience. And very modestly, we will try to do our best in order to be the go-between between your experiences. And thank you very much for your time and pleasure.
Thank you.
So just can I have a comment on the questions already about the home care?
Of course, please go ahead.
No, I believe that home care in France, it's very advanced. So we were used to talk about home care in France 30 years ago. It's a independent structures, were well defined, professionals. And when I came back to Lebanon, and I think we have the same situation in Jordan, we thought that such structures is not needed in our countries because we have the sense of family. Our patients are not living alone, even the elderly one. And we thought that the patients surrounded by the family will accomplish the job. In fact, with time, we are more aware that this structure must be implemented in Lebanon. I think in Jordan they have it's a recent experience. In Lebanon, we have some experience with NGOs that are taking care of our patients for free at the hospital, at their home. We don't have a professionals or independent structures because in our system they are not reimbursed yet. So there is no code for home care to our patients at home. But I think it will come soon in the future. Thank you.
Okay, thank you for your comment, Joseph. We have few minutes for 2 or 3 last questions or comments. Anyone?
I have one question. Did you come or return to the normal at Institut Curie? What are you doing now with at the end of this COVID-19 pandemic?
We are almost normal, not completely. What we have observed in the last 2 weeks is that the daycare clinic now is full. And so the patients who had some chemo at home, most of them choose to come back to the hospital. We also still have many single rooms, so meaning that we still lack beds for patients who need to be admitted to the hospital, and which is for us still a critical issue. We are still limiting somewhat the visits for the family, and again, except for children and patients who are at the end of life. So we are close to normal, but not normal yet. And I guess this will be the case till September.
And all the PCR tests are negative in the entry of Institut Curie from 7 or 8 weeks.
Or more or less, yes. And yes, and Alex is right. So we didn't have any new COVID-19 patients for 3 to 4 weeks now. Okay. But still we are cautious because there are some clusters in France, not in Paris, but there are still some clusters in France, so we are still very cautious.
And on the side of international patients, when we closed the borders, we had 121 international patients under treatment in Curie, and they remain here. I mean, we discussed with embassies, and we maintain the patients in France to be treated. Actually, the borders are reopening, and since last week, we are readmitting international patients. So things are moving slowly to normal.
Are you screening all your patients with PCR for COVID, or patient they should be admitted on chemotherapy unit?
No, we did not at any point. So the screening was based on the clinical symptoms. So either the patients are clinical symptoms suggestive of COVID disease, or they had close contacts with family who had proven COVID-19, then they were tested. And first they were advised not to come to the hospital. So we had an email and text message system warning them to call us before coming if they had any suspicion. What we still do is to test patients who have surgery, but we do not systematically test patients for chemo.
Okay, thank you.
Any other question? Okay, if no, we are going to close this webinar. And really, we wanted to thank all the speakers. Thanks to Professor Daoutou in Vietnam, to Dr. Omar and Hikmat in Jordan, Joseph and Marcel in Beirut, and Paul and Alexis in Paris. Thank you very much. More news very soon. This afternoon, we are starting the same webinar with the Memorial of New York, McGill Cancer Center in Montreal, and AC Camargo in Sao Paulo with our colleagues. Hopefully we are going to learn more. And all together we are going to co-sign a single publications about COVID and cancer management. Thank you very much.
Thank you, Pierre. Thank you.
Thank you very much.
Thank you all.